Hi, my name is Amy Ford, and I would like to welcome you to Competence in Cancer Care, What the Nurse Needs to Know. Today's focus is going to be on cancer therapy symptom management. We know that a symptom is a sensation or a perception of change related to health function experienced by an individual. Symptoms such as nausea and vomiting, pain, oral mucositis may be classified based on their severity and the impact on different types of function. Symptoms definitely add to the burden of having a chronic illness such as cancer and different tumor types that patients have. And we know that with these alterations that it affects all aspects of our patients and their lives. And you can see here in this slide, we are going to discuss different nursing diagnoses related to alterations from hematologic function going down through the GI system, the GU system, looking at skin, also focusing on the respiratory function, cardiovascular, nutritional status, and comfort. In order to understand symptom management, we first need to have an understanding of toxicity and grading scales. And what's important for the oncology nurse to know is that the common toxicity criteria, or the CTC, also referred to as the Common Terminology Criteria for Adverse Events, is a standardized classification of side effects often used in assessing drugs for cancer therapy. Came from the National Cancer Institute, and currently version 4.0 is in use, which was released in 2009. Most United States and European drug trials base their observations on this system, which has a range of grades from 1 to 5. Specific conditions and symptoms may have values or descriptive comments for each level, but the general guideline is that you can see here, the lower the number, the more mild the side effect, and then up to 5 or 4 to 5 is life-threatening and death. And so you will see with many drug trials and many clinical trials that this grading scale is what's commonly used. What's important to note is that there are several types of toxicity and grading scales, different types of inventories related to pain assessment, fatigue assessment, skin assessment. You'll see that throughout the presentation today, and that specific organizations have developed their own toxicity scales, such as ASCO and MASC. And what I think is important for the oncology nurse is that they consistently use an assessment scale and that they document it. Another symptom management tool is understanding the common anatomical and surgical alterations that an oncology patient may undergo, especially when they may be first diagnosed with cancer. They may have some type of surgery. As far as breast surgery, we know that mastectomies are very common. Reconstructive or reparative surgery may be done. As far as colon surgery, if we're aware of colostomies and ileostomies, and this is a picture of a fresh colostomy post-surgery. Patients with lung cancer may have thoracotomies. Patients with prostate cancer may have prostatectomies. And it's important for us to understand that these are common different anatomical and surgical alterations that the oncology nurse may have to take care of and may have to take care of the side effects related to these surgeries. It's important for us to understand complementary and alternative therapies as well. I believe it's important for the oncology nurse to understand the different types listed here. Different complementary therapies have been proven or unproven based on their efficacy, that they've been helped to use to promote wellness, to manage symptoms associated with cancer, and its treatments, and it helps maybe even to treat cancer. When properly combined with standard cancer treatments, some complementary therapies can enhance wellness and quality of life, but others may be harmful. Some may not have any type of benefit. So it's important that we have an open communication with our patients. That really is the take-home message of understanding complementary therapies, is understanding what complementary therapies your patients are participating in, having that open line of communication to assess, and then be able to make recommendations based on what you know as the clinician. There are several different types of complementary therapies you see here, biological based ones such as herbal remedies and vitamins. It's important we know what supplements our patients may be taking. because they may interact and have drug-drug interactions with some of the medicines that we may prescribe. Mind-body complementary therapies such as meditation or expressive arts, manipulative and body-based such as massage, reflexology, and exercise, and energy complementary therapies such as Reiki and healing touch. I would refer you to the National Center for Complementary and Alternative Medicine. Is a wonderful website and organization that's part of the National Institutes of Health, where if you're a practitioner or an oncology nurse, you can go to this website and they have an A to Z list of common complementary therapies that your patients may be participating in. They have sheets that you can print for your educational purposes. And so I think what this does is it helps with understanding what complementary therapies your patients are participating in and the evidence to see if it's okay for the patient to participate in or if there's a harm and if maybe they need to stop taking any particular type of supplement. When a patient visits an oncology clinic, the first thing that usually they have done is their blood counts. And so we're going to start here with hematologic function and looking at blood counts, the red blood cells, the white blood cells, and the platelets. It's important for us to have an understanding of a normal CBC finding in order to know what types of treatments may be given at your clinic. If a patient comes in and has a complete blood count drawn, this shows you Fishbach lab values from 2008. Each center uses their own lab value and lab normal range. It's important for you to understand what your center's guidelines are, at what point you would transfuse a patient. But based on the CBC findings, this is going to determine whether a client or a patient is going to need to receive a transfusion, if they're going to be able to get their chemotherapy infusion. If they find that they're neutropenic, they may need to get a growth factor. Different treatments are based on what the CBC count is. So it's very vital whenever a patient comes into the clinic that we see what is their CBC for the day, because that's going to help determine their treatment. One of the components in reviewing a CBC of a patient is looking at the white blood count and most specifically looking at the absolute neutrophil count. The ANC is a measure of the number of neutrophil granulocytes. The neutrophils are a type of white blood cell that fight against infection. And so in order to calculate an absolute neutrophil count or an ANC count, what we would do is we would take the total white blood cell count, multiply it by the total percentage of neutrophils, the segs plus the bands. The segs are the mature neutrophils and the bands are the immature neutrophils. Normal ANC is above 1,500 cells per microliter, and an ANC less than 500 is defined as neutropenia and significantly increases the risk of infection. We know that neutropenia is a condition of a low ANC, and the most common condition where an ANC would be measured is in this setting where a patient would be receiving chemotherapy for cancer. So if we look at Mary as an example patient, she enters into your clinic and she has a CBC drawn, which is a complete blood count. We see that her hemoglobin is 11.8, her hematocrit is 33.6. She has platelets of 70, which those are all pretty good numbers for a patient coming into your clinic. But we look at her white blood cell count and we see that her white blood cells are 2.9, and that means 2,900. And you see below the white blood cell count is her differential, and the differential is what makes up all the components of the total white blood cell count. Each of the numbers listed below adds up to 100. And if we want to calculate her absolute neutrophil count, we would look at her segs and her bands. So you see that she has 15 segs and 2 bands. So in order to calculate her ANC, which is something I would like for you to do right now, is we would take her white blood cell count, which is 2,900, and we would multiply it by the percentage of segs and bands, which is 17%. So 17% of 2,900 equals 493. A lot of your centers may automatically calculate the ANC, but I would suggest that you would have a working knowledge of this formula and how to calculate it yourself if you needed to. So if we looked at her white blood cell count and we saw that it was 2,900, we would think she's got a good white blood cell count. But once we calculate her true absolute neutrophil count and we see that it's only 493, we know that she is definitely neutropenic and that probably her chemotherapy would be withheld in the clinic that day. Moving on to the assessment of a patient, if we're looking head to toe, the patient comes in for a blood count, and then we're going to take their vital signs. We're going to assess them and ask them if they've been running any type of fever. 100.6 is listed here on this slide. Sometimes it's the standard in some clinics. Each institution and each cancer center has their own specific number that you educate your patients to call you if they have a temperature of this certain level, 100.4, 5, 6, 7, that they would need to call your institution or call the physician, and a judgment would need to be made whether they need to be admitted, whether they need to have antibiotics prescribed. But it's very important that we educate our patients on temperature and specifically taking their temperature every evening and documenting it. It's very important, I think, that they keep a diary and documenting what their temperature is every night so that they can see if there's any abnormalities. Moving on to GI function, we look at several alterations that can occur, different complications such as diarrhea, constipation, impaction, bowel obstruction, and radiation enteritis are common problems for oncology patients. The growth and spread of cancer as well as its treatment contributes to these conditions. Constipation is the slow movement of feces through the large intestines that results in the passage of dry, hard stool. This can result in discomfort or pain. The longer the transit time of stool in the large intestine, the greater the fluid absorption and the drier and harder the stool becomes. If our cancer patients are inactive or immobile, or if they have physical and social impediments, that can contribute to constipation, as well as depression and anxiety caused by the treatments, or the cancer pain can lead to HIP. Probably the most common causes of constipation is inadequate fluid intake and pain medication, but we know that these causes are manageable, and so it's important for us as nurses to assess this so that we can help them with managing it. Different structural disorders, such as bowel lesions caused by primary or metastatic tumors, postoperatively adhesions may affect normal bowel function as well. Patients who have colostomies are at special risk of developing constipation, so if stool is not passed on a regular basis, further investigation is warranted. We know that diarrhea can occur throughout the continuum of cancer care, and the effects can be physically and emotionally devastating. Although it's less prevalent than constipation, it remains a significant burden for people with cancer. Diarrhea can alter dietary patterns, trigger dehydration. It may be something that a patient has to enter the hospital for fluids. Acute diarrhea is generally considered to be an abnormal increase in stool liquid that lasts more than 4 days, but less than 2 weeks. And another definition would be that diarrhea is an increase in stool liquidity, greater than 300 cc's of stool, and frequency, the passage of more than 3 unformed stools during a 24-hour period. Radiation enteritis is a functional disorder of the large and small bowel that occurs during or after a course of radiation therapy, specifically to the abdomen, pelvis, or rectum. The large and small bowel are very sensitive to ionizing radiation. Although the probability of tumor control increases with the radiation dose, so does damage to normal tissue. It's important for us to look at alterations that our patients can experience, and important to assess their urine, their color, the frequency that they're using the restroom, any hesitancy or incontinence that they may be suffering from, any burning or urgency or retention. These may be some signs of urinary tract infections for our prostate cancer patients that are undergoing radiation therapy or have had surgery with a prostatectomy. These are some side effects that we need to be aware of and assessing our patients for so that we can help do early intervention and management for these patients. We know that patients receiving chemotherapy, those cancer cells are dividing at a high mitotic rate. And when a patient receives chemo, those drugs are working by targeting these rapidly dividing cells. And there are certain cells in our body that rapidly divide, like our hair follicles and the cells in the lining of our stomach and digestive tract. And chemo cannot tell the difference between normal versus rapidly dividing cells. So the drug attacks these cells as well. And that's why we have different alterations within the skin, such as alopecia. Patients also may develop rashes from different types of targeted therapy. They may have bruising from low platelet counts. They may develop itching as a side effect of some of their treatments. We also know that there are specific skin cancers that can occur as an alteration in the skin function. And then also, if we have elevated liver enzymes, patients may have jaundice as well. You see here with alopecia that hair and nails are rapidly dividing cells killed by chemotherapy. It can include hair on every portion of their body, from their head, body, nails, eyelashes, eyebrows. Hair normally falls out about 2 to 3 weeks after chemotherapy has started, so I think this is where we, as oncology nurses, can educate our patients to help dispel any myths or fears that they may have. We know that hair will typically grow back 2 to 3 months after chemotherapy ends. And I think the most encouraging thing is that we know that the hair will grow back. It's just that the texture or the color may be different. I've definitely known some patients in my career as an oncology nurse where they maybe had straight hair, and then when their hair came back, it came back curly. So we always said this was maybe a new set of hair that these patients were able to get the hair that they always wanted. Unfortunately, we know that radiation-induced alopecia is permanent, but you can see here that these are definitely some psychosocial issues that your patients may go through, specifically your breast cancer patients, with your breast cancer females that are undergoing therapy for their treatment. This may definitely be something that's disheartening, may cause lots of anxiety and worry. So I think this is a key issue that we can help educate our patients. It's important to understand the ABC rules for preventing skin cancer. And the idea is that we would memorize this acronym, and if there was any abnormality of one of these different letters or ABC rules, that we would seek a physician or a practitioner to do a full body skin check. A is asymmetry, so if there's any type of irregularity from a normal freckle or mole, that you would seek attention to have a skin check. B is border, if there is an irregular border. C is color. If you notice two different color patterns, such as like a dark brown and a light brown, or a dark black and a light black, that would be concerning and you would need to go for a skin check. D is diameter, and I've always memorized it as if it's larger than the size of a pencil head, which is about 1/4 of an inch, that we would need to seek a skin care check to rule out any type of skin cancers. E is enlargement, if they notice the mole growing. And then what's interesting is they've added on an F called feeling. If you notice that the mole is itchy, that would be something that you'd want to seek attention for and understand better if you need to rule out any type of skin cancer. Moving on to other types of alterations in the integumentary system is the hand-foot skin reaction. We know that that is a reaction that can appear on the palm of the hand and the soles of the feet as a result of certain chemotherapy and targeted therapy agents. You may also know it as acral erythema or palmar plantar erythema. You may hear it as PPE. Different drugs known to cause hand-foot syndrome are capecitabine, fluorouracil, liposomal doxorubicin, cytarabine, hydroxyurea, sunitinib, and sorafenib. Hand-foot skin reaction can start as a feeling of tingling or numbness in the palms and or soles, which progresses to swelling, redness, peeling skin, and tenderness or pain. You can see that this is the grading scale that is often used. If there's no change in treatment, the hands or the feet can blister, which can be very debilitating. It also can become infected, which is also very painful for our patients. So it's very important for our patients to know about this side effect related to the different agents and that they notify their clinician at the first sign of it. Most patients will develop hand-foot skin reaction within the first few weeks of therapy, but it also can happen after being on the medication for many months. Here are some photos looking at grade 1, grade 2, and grade 3. No one really knows for sure what causes hand-foot skin reaction, but there are a few theories. The most widely accepted theory is that the small blood vessels in the palms and our soles break due to use, pressure, or increased temperature, causing inflammatory reaction and possibly releasing the drug into the area. There are many suggested prevention strategies or treatments, and that's what's all based on this theory. So, some basic interventions for our patients to avoid tight fitting clothes, such as socks or stockings or tight shoes. Wear loose, comfy shoes when going out and slippers around the house. Do not go barefoot. Avoid activities that rub the skin or put pressure on the palms or soles for 1 week after treatment. Apply a moisturizer to your hands and feet liberally and often, but gently to avoid rubbing the skin too harshly. It's important to use creams that are highly emollient. Some examples are Bag Balm, the Utterly Smooth Cream, Eucerin, and Aveeno. But avoid any lotions or creams that contains perfume, alcohols, or glycerin. Specifically, avoid hot water, such as a hot tub, hot bath, or shower, or when washing dishes. Use warm water to shower or bathe, and keep showers and baths very short. Use tepid water when washing dishes, and specifically avoid sun exposure as their skin is very sensitive to the sun while on treatment. Wear an SPF 30 or higher daily, or wear long sleeve shirts or pants. These are just several interventions that can be suggested to our oncology patients undergoing treatment. Remember, the main goal for us as nurses is to help keep our patients on treatment as long as possible, and this is where we best can do what we're so good at, which is experts at symptom management and helping them stay on therapy as long as possible. Moving on to another type of skin alteration that you may be familiar with is the EGFR rash, which is the epidermal growth factor receptor rash. It's a common skin-related side effect of certain medications, targeted therapy, and chemotherapy. The dry skin rash is characterized by mild scaling, pimples, roughness, or feeling of tightness and possibly itching and burning. When this first came out several years ago, you heard it referred to as acne-like rash, and now the more common term is the EGFR rash. They may also have a maculopapular rash, which macular means small flat areas and papular is small raised lesions. The rash may range in color from light pink to bright red and may feel very hot. The rash is usually preceded by redness of the skin or a warm sensation on the face that may feel like a sunburn. And sometimes the rash leads to peeling and lesions as well. They may develop these acne-like red bumps, often in clusters, commonly appear on the face, neck, chest, scalp, and back. Many types of chemotherapy and targeted therapies may cause the EGFR rash, including gefitinib, erlotinib, cetuximab, lapatinib, panitumumab, and some tyrosine kinase inhibitors. Skin rash is a common side effect, and it affects more than 50% of patients receiving epidermal growth factor receptor inhibitors. And what's interesting to note is that several studies have demonstrated a positive correlation between rash and tumor response and survival. And so it's important for us as nurses to keep our patients on therapy, and if they start to experience this rash, for us to intervene when it's still at the mild level and hopefully not progress to moderate or severe so we can keep them on therapy. Some suggested interventions that are just do's and don'ts with the EGFR rash is just understanding this related rash and knowing that it's not an acne rash, encouraging our patients not to go to their teenagers' cabinets and start taking out the Oxy and all of the different acne medications that teenagers use for facial treatments, that they would use very emollient creams and that they could put these creams and lotions in the refrigerator. The more cooler they are, the more comfortable it usually feels when they apply it. And try not to use a very thin lotion, but just the thicker the better. Avoid the sun. Don't use products with any type of alcohol. And apply moisturizer within 15 minutes of showering when their skin is still damp. And not getting a facial. Some people believe, oh, I'll go get a facial and this will clear up my rash. Nurses should visually examine affected areas and grade the severity to determine appropriate interventions for management of the side effects. Early and prompt intervention for management may help keep patients on therapy longer. Another nail change, which is a skin alteration, is the paronychia. It's described as painful inflammation of the tissue around fingernails and toenails. This may be observed with patients that do receive agents that cause the hand-foot skin reaction. It's commonly seen in the big toe and thumbs, and it's observed in about 12 to 16% of patients. It's often delayed and may develop after 4 to 8 weeks of treatment. So symptoms may be improved by wearing shoes that are not too tight, avoiding friction, hot soaks, and cushioning to provide comfort. Epsom salt soaks help promote drainage, and topical antiseptic ointments may help. If you've ever taken care of a stem cell transplant patient or a bone marrow transplant patient, these pictures are showing a patient that has chronic graft versus host disease. We know that graft versus host disease is a common complication following an allogeneic tissue transplant. Allogeneic is when someone donates their cells, either a sibling or an unknown donor may donate their cells to a patient that needs to undergo a stem cell transplant. Immune cells, or the white blood cells in the tissue called the graft, recognize the recipient, which is called the host, as foreign. And what happens is this process of graft versus host disease, so the transplanted immune cells then attack the host body cells. So the acute form of this disease is normally observed within the first 100 days post-transplant and can be a major challenge to transplant patients and to clinicians owing to lots of morbidity and mortality. The chronic form of GVHD normally occurs after 100 days, and the appearance of moderate to severe cases adversely influences long-term survival. So if we move on to alterations in respiratory function, we can assess our patients for shortness of breath, wheezing, any type of cough, sputum abnormalities, and we can try to help intervene as early as possible. We can encourage our patients, and you see here on the right different pictures with the pursed-lipped and diaphragmatic breathing, elevating their pillows, and sitting upright in a chair. These are different interventions, but it's important for us to assess our patients, and if they're complaining of any type of cough, shortness of breath, that they would report it immediately. There are certain medications that may cause pneumonitis or a non-infectious pneumonitis, and it's important for us to be aware of it so that if we need to intervene with antibiotics or steroids, or if medications need to be halted for a time, or patients maybe need to be put on a drug holiday or a break, it's important that we understand this, especially when we're in cold and flu seasons, that they report these signs and symptoms. It's important for us to assess our patients for any type of chest pain or swelling, palpitations, or radiation. There are several chemotherapy and targeted therapy agents such as bevacizumab, which may affect the blood pressure. Trastuzumab may affect the blood pressure as well. Specifically with cardiac function, doxorubicin is important for our patients to assess any type of ejection fraction so that we make sure that our patients are being properly managed while they're on treatment. An important lab value when a patient enters the clinic or is hospitalized is to look at their potassium and to make sure that they can maintain a normal potassium level, because we know that either an increase or a decrease can cause significant side effects with our patients. So it's always prudent and important that our patients maintain a normal potassium level, and you can see here the different side effects that can cause depending on the increase or decrease in level. If we assess for neurological function, it's important that we are ruling out any type of fainting or dizziness. The patient may be dehydrated. They may be complaining of some type of seizures or having a numbness or tingling, which is a neuropathy, headaches, assessing their orientation or trouble with balance, because we may be ruling out a brain metastasis in some of our patients. Some of our patients do have different types of brain tumors, and it's best if we can help assess that so we know how to properly manage it. More specifically, peripheral neuropathy or neuropathies are an irritation or damage to the nerves, which can cause poor communication between the nerves. It affects the motor, sensory, and autonomic nerves. Certain chemo agents can cause this damage, creating a challenge for both patients and the practitioners. and balancing the goal of cure with the patient's quality of life. The incidence can vary greatly among patients being treated with chemo. There was a study back in 2008 looking at 30 to 40% of cancer patients receiving chemotherapy will develop chemo-induced peripheral neuropathy during their treatments. With an incidence this notable, there's a significant importance for healthcare providers to have an appropriate understanding of the pathophysiology risk factors, the symptoms, and the management. Symptoms exhibited by patients who present can include both sensory, motor, and autonomic dysfunction, which can include paresthesias, hyperesthesia, hypoesthesia, including a temperature decrease or misperception, different types of pain, numbness and tingling. I know I've had patients explain it as just a burning fire, it feels like, in their hands and feet. So patients may have cool, hairless, dry, and or thin skin in the affected extremities. So it's important that we help with interventions, specifically with our patients with neuropathy. And I always think of taking care of like a diabetic patient. What are some of the interventions we usually recommend to them, such as always wearing shoes, not going barefoot, basically the same things you would think of with the hand-foot skin reaction or the EGFR-related rash, is avoiding hot water, hot showers, being careful when they're cooking with the hot stove, removing rugs in their home, specific interventions that would be helpful to help reduce any type of further damage with the peripheral neuropathy. If we move on to alterations in musculoskeletal function, we know that these patients may complain of different types of pain, fatigue, sleep disturbances, fractures, muscle strength, and limitation of motion. So it's important for us to assess this so that we can help intervene appropriately and quickly. Very important that we assess our patient's nutritional status. We know that patients may have a weight gain or weight loss that are undergoing different types of treatment. They may experience weight loss related to the side effects that affect their ability to eat. It's important to eat whatever works during this time to maintain body weight and protein stores. It's very important for them to add protein to their diet. Some women, though, undergoing breast cancer treatment may have unwanted weight gain during or after the treatment process. The reason for this weight gain is not clear, but may be due to hormonal changes, as well as decreased activity, depression, and other factors. It's helpful to know for patients that are undergoing breast cancer treatment that this may be a side effect. Good nutrition is important for people with cancer. That is because the illness itself, as well as its treatments, may affect their appetite, and it may affect the body's ability to tolerate certain foods and to use nutrients. So eating well while undergoing cancer therapy can definitely help a patient feel better and can help with any nutrition goals and strategies that we as oncology nurses can help intervene with. Some particular interventions is to watch out for certain foods. This is a collage of different foods and other substances that you are all probably familiar with that patients have told us have really interfered with specifically their chemo-induced nausea and vomiting. If you notice in the picture, there's a lot of hot, spicy foods. There's also caffeinated drinks, greasy foods, high-fat foods. So the idea is that they would avoid high-fat, greasy, caffeine-related foods because that may help induce more of their nausea and vomiting, and the more they can prevent, the better. They suggest that you should avoid caffeine. Some patients do like carbonations, but some people say that it does upset their stomach. Avoiding alcohol is very important during their treatment. Pizza, greasy foods, hamburgers, french fries. It's probably better if you were to go to a fast food restaurant as a cancer patient that you would avoid those greasy foods and that you would make better food choices, such as more of the grilled chicken sandwich, something with more protein. Another thing that can stimulate nausea and vomiting specifically is the hot foods. So it might be best to have cold foods and have them already prepared and put into the refrigerator. So if we move on to this next slide, we look at tips for a poor appetite. Eat small meals or snacks every 1 to 2 hours. Avoid liquids with meals to keep from feeling full early. Make eating more enjoyable by setting the table. I would always encourage my transplant patients when I worked in bone marrow transplant to make sure that they did not eat and sleep and do everything in their bed, that they would get up and go to the table or go to the couch, and that they would eat their dinners there, maybe on a TV tray or something while visiting with friends or watching TV, and that they would always keep high calorie, high protein snacks on hand. Moving on to different comfort measures as far as alterations in symptom management, we're going to look at pain. And Margot McCaffrey is a pain management thought leader. And she said back in 1968, pain is whatever the patient says it is and exists wherever he or she says it does. So it's important that we as nurses respect that with our patients and respect their assessment and what they tell us that they are having with pain. And what we can do is the best that we can do with assessing them by using different types of pain scales and then helping intervene appropriately. There are different types of characteristics of pain. Acute pain usually lasts less than 6 months. The cause of the pain is often known, and objective pain behaviors are more frequently exhibited. Another characteristic is chronic pain, which usually lasts longer than 3 months. The etiology of the pain is often unknown. It often does not respond to multiple treatment regimens, and fatigue and depression are common with patients that have chronic pain. And then cancer pain includes acute cancer-related pain caused by the cancer or cancer therapy. It includes chronic cancer-related pain from tumor progression or cancer therapy. And then increased pain may precipitate fear of cancer progression. Increased pain worsens anxiety, hopelessness, and depression. There are also different types of pain. Somatic pain is usually well localized and characterized by an aching or gnawing sensation. Visceral pain is the result of the activation of pain fibers in the thoracic or abdominal tissue. It's usually poorly localized and it's characterized by an aching sensation. And then last, we have neuropathic pain, which is the result of compression or injury to the peripheral, sympathetic, and/or central nervous system. If we look at risk factors in pain management, we can look at two different buckets: treatment-related risk factors and disease-related risk factors. Patients that are receiving chemotherapy, the toxicities of the drugs themselves may cause different types of mucositis, peripheral neuropathies, and herpetic neuralgias such as shingles. It often occurs from the immunosuppression of the chemo, and that's characterized by burning, aching, and shock-like pain in the area of the lesions. Patients that are receiving radiation therapy may also develop the mucositis, which occurs with radiation therapy to the head and neck. Radiation may induce peripheral nerve tumors characterized by a painful enlarging mass in a previously irradiated area. And then patients also can develop the radiation skin burns from treatment. There's also pain related to cancer surgery. Our breast cancer patients may have post-mastectomy pain, which is characterized by tightness in the axilla, the medial upper arm, and/or the chest. Patients that have undergone a thoracotomy, they may have an aching and a sensory loss in the incisional area, as well as patients that have undergone a post-limb amputation. They may develop stump pain, which is a burning sensation exacerbated with movement, or phantom pain, which is characterized by cramping, throbbing, and burning in the former anatomic location of the amputated limb. We look at disease-related factors. We know that bone metastasis is the most common source of cancer pain. That pain is the result of bone destruction or compression of the bone on nerves and soft tissue. We also have abdominal visceral pain, which may be caused by tumor obstruction in the small or large bowel, a liver metastasis, blood flow occlusion to visceral organs, and other causes as well. And then last, we may have nerve compression, which is injury to the peripheral, sympathetic, and/or central nerves, such as a spinal cord compression. If we look at the management for pain, you see listed below here are surgical interventions, also non-pharmacologic interventions such as a TENS unit, which is the transcutaneous electrical nerve stimulation, occupational and physical therapy, complementary therapies such as distraction, music, guided imagery, hypnosis, massage, or relaxation. number one, we want to treat the underlying cause of the pain. And then you see here in a stepwise fashion for pain management with medical management, step one is non opioid analgesics. Step two is weak opioid analgesics. And step three is strong opioid analgesics. The World Health Organization has a ladder called the WHO ladder, and that is used commonly with cancer treatment regimens for pain management. If we look at the assessment of pain, we know that pain is often called the fifth vital sign, but we want to assess the location, the intensity, and the quality of the pain. We want to make sure that pain should be assessed in each client with cancer. It should be assessed with each new report or increase in pain. It should also be reassessed after appropriate intervals following pain intervention. And if you would like more information on pain management, I will refer you to the end of life care and survivorship module, which discusses pain as well, and for further instruction can give you some more information. We have our 4 vital signs. The 5th vital sign is usually pain, while fatigue is called the 6th vital sign. We know that it's an unusual, abnormal, or excessive whole body tiredness that is disproportionate to or unrelated to activity. This is something that I have found over my career that patients told me about or asked me, why did no one tell me about the fatigue I was about to have? I was completely unaware of all the fatigue I would suffer from. It has become debilitating and it has totally affected my quality of life. 1/3 of all cancer survivors report fatigue as a long-term effect of cancer treatment. The cause of a person's fatigue may be due to different types of treatment, pre-existing conditions, such as anemia, pain, a sluggish thyroid gland, lack of physical strength, or depression. It may simply be caused by the different activity with their cancers, different types of symptoms related to the cancers, or just simply the demand of dealing with cancer. The stress on the body may cause the fatigue, and you may have heard it as a chronic fatigue syndrome. There are different types of fatigue inventories or fatigue scales that we can use, and it's important for us to assess this in our patients, that we not ignore it. Sometimes this can be the elephant in the room that nobody wants to talk about. I think it is important for us to be upfront and honest with our patients about it, and that we can help them understand better some interventions, different types of impact on their functioning, but really bringing through what are some relieving factors, if it's helpful with interventions such as grouping their activities during the day, trying not to nap too much during the day, but sleeping all through the night, looking at not taking on too much as projects, maybe only working part-time instead of full-time, working when they have the most energy during the day, different interventions that we could consider that we can help with, but basically not ignoring it, but bringing it to the forefront and letting them know that this may be something that they may experience. Moving on to another alteration is specifically oral mucositis, and this is very common in our oncology patients. This is a slide looking at risk factors, and we can definitely look at some patient-related risk factors. The younger patients usually have a healthier dentition than older patients. So the older a person is, they may have more problems with periodontal disease or their dental hygiene. They may have defective restoration or orthodontic appliances. They may have ill-fitting dentures and other potential sources of infection and cavities. Poor dental hygiene in combination with dental caries and periodontal disease leads to a greater risk for mucositis during the course of chemotherapy. Patients with dental caries may have all their teeth removed prior to head and neck radiation, and ill-fitting dentures can cause irritation to the oral mucosa, placing the patient at risk for mucositis and infection. Some other risk factors such as tobacco use, alcohol use, poor nutrition, and poor oral hygiene may be ones that can be modified through patient education. Other factors such as malignancy and genetic factors are those which cannot be altered. Oral mucositis can be high as 100% in certain patients depending on their risk factor and treatment regimens. So what are some patients in your practice that you can predict will have oral mucositis? Just some FYI information, about 40% of patients receiving standard dose chemotherapy will experience mucositis, 60% receiving high dose chemotherapy, and those that are at risk 100% are your stem cell transplant patients and your head and neck patients. This is the World Health Organization scale, which includes a 0 to 4 rating, with 4 being the most severe. The pictures to the right are courtesy of Dr. Toth from MD Anderson Cancer Center. This scale, the World Health Organization scale, is one that is commonly used in clinical practice for an assessment of the oral cavity, and it's important for nurses to assess the mouth and to document and to grade what type of mucositis the patient has in order to intervene appropriately. Grade 1 mucositis, according to the WHO scale for oral toxicity, we know that may be often hard to see the slight changes in the oral mucosa. The patient may complain of mild overall soreness, and the trained nurse may see signs of erythema. It is important to ask the patient if they feel any soreness, tenderness, or ulcerations. Important areas to include in your assessment besides the teeth and gums are to look at the buccal areas, the hard and soft palate, and under the tongue. It's very important to teach patients to assess their mouth daily in order to promptly report any changes so that early interventions can occur. We do have some oral targeted therapies that can cause oral mucositis, and so it's very important that we intervene as early as possible. We know with grade 2 mucositis, using the World Health Organization scoring system, that patients may have oral erythema with patchy areas of inflammation or ulcerations. A solid diet is still tolerated, but typically patients experience moderate pain that requires intervention with analgesics. And the goal is to help intervene at grade 1 or 2 so that our patients do not have to go to a grade 3 or 4, because if we can't keep them at a grade 1 or 2, the patient may have to stop therapy. And remember, our main goal as oncology nurses is to keep our patients on therapy. Grade 3 is the oral mucositis, involves oral ulcerations in which liquid diet only is tolerated. This is very painful. Patients often experience severe pain, which is requiring narcotics, and the pain often prevents swallowing of required hydration and nutrition. Unfortunately, grade 4 is the worst mucositis possible. The patients may have severe ulceration with hemorrhaging or necrosis. I have never seen grade 4 mucositis, but I have some friends that worked in bone marrow transplant in the ICU setting, and they did see this, and the patient had to be intubated in order to protect against aspiration pneumonia. And the patients that my friends saw were only bone marrow transplant patients, and they had received high-dose chemotherapy and total body radiation. So some interventions that we can help with as far as oncology nurses to help intervene in the alteration with the oral mucosa is looking at some different tips. A toddler toothbrush may be easier for a patient to use. It is usually softer than an adult soft toothbrush. It's also shorter with the larger handles, so patients with neuropathies can often use it easier. If a patient has always flossed, they can continue flossing every day, but now is not the time to start flossing if they never have. Different studies will look at different thresholds of platelets, but it's prudent that our patients perform good oral care every day, and they brush their teeth after every meal and at bedtime, that they rinse with salt and soda solutions, that patients would take very special care with dentures, especially if they've lost a significant amount of weight. Their dentures may not fix properly. And then also dietary modifications, that patients would be careful with what their diet is. Some patients may be eating lots of chips and hot sauce and hot foods and spicy foods. So it's important for us to educate our patients on dietary modifications. The recipe for salt and soda rinses is 2 teaspoons of baking soda with 1 teaspoon salt in 1 liter of water. It's recommended that they make a fresh solution every 24 hours. Another intervention is that you could have them do a smaller amount in about 8 ounces of water, and that they perform these rinses before and after they eat meals and before and after they take their medicines, at least 4 to 6 times a day. And it's important that they're consistent and that they use mouth rinses. whether they're using salt and soda rinses or other recommended mouth rinses. There are several out on the market. I think the most important part is that they stay consistent and that they start with day one of chemotherapy, and they may start with day one of different oral targeted therapies that cause stomatitis or mucositis. Another alteration that can affect our oncology patients is chemotherapy-induced nausea and vomiting. As you can see here on the slide, CINV may affect your overall health. We know that there are different risk factors, and the risk for developing CINV is based on treatment and patient risk factors. Treatment factors include different types of chemotherapy agents that they may be receiving, the immunogenicity of the different drugs and the therapies. We know that patients don't just receive one chemo drug these days. They usually receive a regimen of multiple drugs, and those drugs are working synergistically together that may cause that whole regimen to be more highly emetogenic. The dose frequency, the route of administration, and then if they had poor control of prior therapy, that will put them at higher risk for developing CINV. Patient risk factors is looking at the younger the age, a female gender, a history of nausea with pregnancy. Patients who've received prior chemotherapy, they tend to have more risk of symptoms than chemotherapy naive patients. If they had a susceptibility to motion sickness or a history of GI problems, just nausea and anxiety in patient perception puts them at a higher risk. This slide just shows you some selected drugs for the emetogenic potential of different chemotherapy agents. Dr. Hesketh and different other thought leaders, Chris, looked at the emetogenicity of different drugs, and we know that cisplatin is our most highly emetogenic chemotherapy. This drug causes the most nausea and vomiting. We also know that this emetogenic potential goes from minimal, low, moderate, and high. And we know that, once again, we're not giving just a single agent anymore. We usually are giving a regimen of multiple agents. And so we know if we're giving more than 2 or 3 moderates, that would become a highly emetogenic regimen, and we would want to treat it with the appropriate treatment options. This is a slide that shows you the process that causes nausea and vomiting. When a patient receives chemotherapy, serotonin is released from the GI tract, and that's a neurotransmitter. And these neurotransmitters bind to the 5-HT3 receptors, which then travel to the chemoreceptor trigger zone and the vomiting center in the brain. And if you think about what physiological symptoms occur when you're about to vomit, I know I get sweaty, I may have some redness, some flushing, my heart rate may increase, and then I vomit. So the goal of the current medications in the armament called 5-HT3 receptor antagonists, they are to block at the chemoreceptor trigger zone in the vomiting center, therefore stopping the vomiting from occurring. Our 5-HT3 receptor antagonists all end in tron that you may be familiar with: palonosetron, ondansetron, dilazotron, and granisetron. There are several different agents involved and neurotransmitters involved. Specifically, this shows you emesis. We have several different types of neurotransmitters, and so there are agents, specifically the serotonin 5-HT3 receptor antagonists. We have a substance P, which is sometimes called an NK1 receptor antagonist. We have different dopamine receptor antagonists. The cannabinoids have been most recently studied, looking at how can we help stop emesis. And so the idea is to use a proactive regimen of multiple drugs to help prevent nausea and vomiting from occurring. If we look at the classification of CINV, we know that acute nausea and vomiting occurs within minutes to hours after administration of chemotherapy, but usually resolves within 24 hours. Delayed nausea and vomiting can occur at least 24 hours after chemotherapy and may last several days. So it's important for us to understand regimens that our patients are receiving. For example, delayed is common with carboplatin. Carboplatin Taxol is a very common regimen that is given to our patients. And if you're giving it, say, on day 1 or on a Monday, we know that by day 3, the afternoon of day 3, that carboplatin may cause some nausea and vomiting. So it's important that we have those medication management on board for that delayed therapy or the delayed CINV. Anticipatory nausea and vomiting Still occurs in about 25% of all patients, and it almost becomes a conditioned response if, with prior chemotherapy treatments, the CINV was not managed. Moving to alterations in sexuality, we know that sexuality is a complex characteristic that involves the physical, psychological, interpersonal, and behavioral aspects of a person. Recognizing that normal sexual functioning covers a wide range is important, and we know that many types of cancer and cancer therapies can cause sexual dysfunction. Research shows that approximately 1/2 of women who have been treated for breast and gynecologic cancers experience long-term sexual dysfunction. Men who have been treated for prostate cancer report problems with erectile dysfunction that varies depending on the type of treatment, and less is known about how other types of cancers, especially other solid tumors, affect sexuality. Specifically, people with HIV are at a higher risk of some types of cancer compared with uninfected people. People with HIV are 25 times more likely to be diagnosed with anal cancer than uninfected people, and infection with HIV weakens the immune system and reduces the body's ability to fight infections. Sexually transmitted diseases like HPV, the human papillomavirus, account for about 5% of all cancers worldwide. Most specifically, the type 16 and 18 comprise the majority of cervical cancers. I would encourage you all to bookmark these two websites, fertilehope.org and livestrong.org, where they give lots of counseling information to young adult patients with cancer on sperm banking and fertility preservation. These are important topics that we discuss with our patients. In order to begin the discussion of sexuality with our patients, this definitely is an issue that I am passionate about because we want to make sure that our patients feel very comfortable in talking about this with the nurses or with the practitioners. Most patients will feel very uncomfortable with talking about it with their spouse or with their loved ones, and so this is a really open line of communication that you as the oncology nurse can be an advocate for them. And Jack Annan, back in 1976, created the PLISSIT model, and the PLISSIT model is to open the discussion of talking about sexuality in our cancer patients. So with PS permission and LI limited information, understanding what information they have, asking permission to discuss the sexuality with them. SS is specific suggestions, and then IT is intensive therapy. What types of education, what types of counseling do these patients need to receive in order to help with their sexuality? So if we've reviewed a lot of the alterations that our patients undergo, what's an awesome topic to be able to talk about today is survivorship issues, that our patients are living longer and longer. But with that comes physical concerns, practical concerns, and spiritual concerns. And cancer survivorship begins at diagnosis. We know that a diagnosis of cancer leads to a change in a person's priorities regarding relationships, career, lifestyle. It's a unique journey for each person, and it can be prioritized into these 3 different buckets. Some cancer survivors are at risk for developing late side effects, which can occur more than 5 years after a diagnosis of cancer because of the related treatments. With the increase in the number of cancer survivors in recent years and the fact that they are living longer, treatment of late effects is becoming a more important component of cancer care. This is one of the last slides, and I think Florence Nightingale was a very true woman of wisdom. Back in 1867, that she said, "Inoculate the country with the view of prevention instead of cure." And I think we've definitely seen a paradigm shift occurring with symptom management specifically. Strategies now are aimed at preventing the symptoms instead of managing the symptoms. Current practices in oncology treatment are to try to be proactive in the management of symptoms instead of being reactive. Studies include even looking at other things on how we can be more preventative. And the more preventative we can be, especially if we know with like health promotion and our screening tools, instead of being reactive. So I think it's an awesome time, and I think your care counts as an oncology nurse, and I think this is an area that you all are usually experts in, and this is the best way that we can show our true calling is helping our patients to stay on treatment as long as possible. We have reviewed many, many things today, and we can look at what we have reviewed. The toxicity and grading scales, it's important that we have an assessment tool in order to document different surgical management options, looking at the importance of complementary therapy and having an open mind with our patients so that they feel comfortable in telling us all the different maybe herbal medicines or supplements that they're taking. And then we looked at all the alterations from the hematologic system, from the GI, the GU functions, from the skin, the integumentary function, respiratory, cardiovascular. We also reviewed neurological function, and then most specifically these different comfort measures: pain, fatigue, mucositis, CINV, sexuality, and then most recently with survivorship. I want to thank you for attending today's module. Thank you. Listed below are some web resources that you may find helpful in furthering your study in symptom management.